Hello, Satyaji.
Yes.
Shall we start?
Yeah. You can go ahead, Dr. Sanjay. It's all there.
Okay. So, good evening, everyone. Welcome to the Asset. Today's Asset is a part of iconic week program of the Azadi Ka Amrit Mahotsav. As you all know, our freedom struggle involved many movements. Disobedience movement, Khilafat movement, Quit India movement, all those things. Coincidentally, today's Asset is also related to movement, but it is body movement. Body movement is an essential aspect of human life. Human movement begins in the uterus as early as 16 to 25 weeks of intrauterine life. All our activities involve some or the other kind of movement. And movements are so natural that we take them for granted without thinking whether any certain movement is correct or not. Brain and neurotransmitters control the body movements. Muscles, bones, ligaments, they help to carry out the movement. And our body weight and other comorbidities also have indirect or direct effect on our movements. As you all are aware, physiotherapy is a crucial aspect of treatment for any neuromusculoskeletal disorders. So today's asset topic is movement in health for health. Application of human movement science in healthcare for health and wellness. Our speaker today is Dr. Rajani Mullerpatan. Dr. Rajani studied BSc and MSc Physiotherapy from Mumbai University and PhD from Cardiff University, UK. Presently, she is associated with the MGM Institute of Health Sciences, Navi, Mumbai as a professor and director of MGM School of Physiotherapy and MGM Center of Human Movement Science. Formerly, she has served as a faculty of physiotherapy at Manipal Institute of Higher Education, India, and University of Nottingham, UK. Dr. Rajani is a member of the Development Group for Low Back Pain, a part of WHO Rehabilitation Program on development of interventions for rehabilitation. She is a member of Research Grant Commission of Society of Indian Physiotherapists. She has also been an Executive Council member of International Society of Biomechanics. Dr. Rajani is a human movement scientist and physiotherapist. Her work is directed towards integration of movement forms involved in traditional sports, yoga, dance, etc. to develop health promotion strategies. Currently, she is focused on development of biomechanics in India to meet the healthcare needs of Indian population. She has collaborated with leading national and international institutes in UK, Canada, and Australia to promote training and research in health promotion, clinical biomechanics, clinical rehabilitation, and technology design. She has also mentored PhD, MPT, and MTech students. She has developed 6 technologies, of which one has been transferred to industry. Dr. Rajani's passion and commitment, along with a dedicated team, is the main driving force for activities of clinical service, research, and training at MGM Institute. This is the shortest introduction I could just summarize. Now, without further delay, I hand over the mic to Dr. Rajani, and I make my movement to chair.
A very good evening to all of you here.
Let's check it.
So I'm pleased to bring along greetings from MGM Center of Human Movement Science. This is a center of excellence of MGM Institute of Health Sciences. It's basically a deemed to be health university in Navi, Mumbai. And From there to all of you who are a family of fundamental scientists, research scholars, what we are going to focus today at this prestigious asset forum of TIFR is about a movement in health for health, which Dr. Sandhya Raghavan and Dr. Satyanarayana Bisite. I'm thankful to both of them for giving me this opportunity to share our ongoing experience of how do we create this. We'd like to make a beginning with what is the need for reform and why is it so essential to reflect upon movement in health in India. Of the three key dimensions of the HDI index, one of them is long and healthy life, along with the other two of knowledge and a decent standard of living. And out of the 17 sustainable development goals, several are targeted towards this long and healthy life in India. And if we have to make a difference here to the HDI index of the country and to the human development of the people, then these are certain burdens that we need to all understand. Particularly when we talk about health, we have the burden caused by the communicable diseases, which all of us have witnessed in the very recent, which is still ongoing, the battle. The thing about communicable diseases are because they are caused by all these different array of organisms which can spread from one to another, they tend to take attention, grab attention of the health systems, of the economic systems and the social systems of the country and demand action on a war footing. Whereas the non-communicable diseases, by the virtue of those, because they do not spread from one to another, tend to be neglected and tend to go on the back burner in most of the developing nations where health resources are already constrained. But the time has come that the world has woken up to the huge burden of non-communicable diseases in both the developed and the developing nations. And largely because of these major killers that we have. And out of those, a few are the cardiovascular diseases, neurological diseases, cancer, diabetes that we all aware of. And that's why WHO and both the World Confederation of Physical Therapy have taken this up as one of the initiative as movement for health. Another need for reform and to transform the pace of movement in health is also the way our technology development has happened. If you refer to the TIFAC document of Technology Vision 2035, India has made huge progress. It's galloping in IT industry, in various other aeronautical and other sectors of industries. But when it comes to health, we are still walking and taking baby steps, even 75 years after our independence. And that's the need that we are waking up to. And to just cite an example of the burden caused by these non-communicable diseases across lifespan. So right in childhood and even at birth, we have this major challenge of neuromotor disabilities, which are caused by developmental delays of certain children who are born with this because of the hypoxic brain damage that occurs at birth. And the prevalence rates are like 1 in 1,000 for Down syndrome and roughly 4.7 for neural tube defects globally. And these numbers are similar in India. In fact, the burden becomes more pronounced in India because not only that our healthcare system is not yet ready to handle them, but nor is our social and environmental system also ready to handle. These are the common disorders which we come across in most families. Due to aging, osteoarthritis is one of them. The prevalence is huge and it's increasing rapidly due to various lifestyle changes that have occurred, various changes in diet and nutrition. Women tend to have more symptoms compared to men. And this is the 10th leading cause of non-fatal burden. So when we say non-fatal burden, there is no death here that has occurred because of the disease, but there is huge socioeconomic burden that's caused because of lack of function that occurs. Another common condition is stroke caused by, and when we talk about stroke, we talk about the damage that occurs to the brain and the damage that occurs even to the heart. So you could have two types of stroke, cardiovascular as well as cerebral ischemic attacks. And these are the prevalence figures, which are huge once again. Another burden that is out there, even in our young lads, is amputation, largely due to road traffic accidents. And then the second cause is diabetes, which is rising, out of which road traffic accidents are huge. And you see these children, I mean, these youth who are right there at the beginning of their career, having to entirely change radically the way they function in the society, because we're still not ready, or we still do not have an accessible or inclusive environment in our country for these people. Another very, very common disability burden, which it is claimed that every individual at some point in life has been affected by this or tends to get affected, and that is spine pain, which is what the world is looking at now usually, because there are certain developed nations which are facing a huge financial burden because of this, because of the claims made by absence of leave. And of all these risk factors, if you look at both modifiable as well as metabolic risk factors, in a country like ours, where resources are strained for management of communicable diseases, stretching them to non-communicable diseases then becomes a further challenge. And therefore, the best way would be to invest our efforts into prevention, and best way would be to invest our efforts in modification of these risk factors. And if you look at the modifiable behavioral risk factors, which can very easily be modified, the four major ones are smoking, unhealthy food, alcohol, and physical inactivity. Now, physical inactivity is something that all of us are experiencing due to pressures at workplace, pressures at managing both and different sectors, and multitasking various activities in our daily routine, that we really tend to find and are always posed with this million-dollar question: when do I find the time for physical activity, or how do I get it? But we have to understand that this particular factor, the modifiable behavioral risk factor, which is physical inactivity, tends to influence all these four major metabolic risk factors: hypertension, hyperglycemia, which is increase in the glucose levels; hypertension is increased blood pressure; obesity is an increase in body mass; and hyperlipidemia is increase in the cholesterol or the fat levels. And these four metabolic risk factors are controlling a huge quantum of non-communicable diseases, right from hypertension to diabetes to cardiovascular diseases and stroke factors. And therefore, it is essential to reflect back on how can we increase this physical activity, and that's where the science of movement comes into the picture. So when we talk about human movement science, most of you sitting around in this audience would be familiar with the movement of the astrophysical elements in the galaxy, and you would be looking at motion at the atomic level, at the molecular level. Similarly, the science of human motion has certain factors which influence these. The factors more or less remain similar. So both these sciences are quite similar, just that human motion science engages some of the elements of exact sciences like mathematics and physics to be applied on the marvel of the human body, to understand the mechanics, both in the healthy state and then in the state where this movement is impaired, or because of a disease, because of a disorder, or because of some injury. So we are going to now run through as to how and what are the elements of human motion. So when we talk about a science of a particular movement, or when we look at movement, even the movement as I walk now, we look at the kinetics of the movement. That is, what are the forces which govern this movement? There are several. There's gravity, there are muscles acting, there are ligaments around the body which control this motion. Along with that, there is kinematics. So we study actually the motion in 3 dimensions, 2 dimensions, depending on whatever the facilities that are available. So that's kinematics. Energy cost is because the human mechanics or the human body is driven by this heart-lung machine, which provides the energy for any particular movement in order to make that movement sustainable, to make that movement energy efficient. So that's where the energy cost, and of course the muscle activity. The muscles are active pumps of movement, and these are the ones which provide the activity governed by the neural control, which is centrally there in the brain, and of course the peripheral nervous system, which has the nerves peripherally sending the signals. So that's where the MGM Institute of Health Sciences established a center of human movement science, because so far movement science has been a science highly developed in the Western countries in the last half of a century. But in India, people have been working in silos, engineers either in the engineering institutes, working at the mechanics bit of it, or the clinicians and healthcare professionals working in health institutes, focusing on the bio. So there was a need to marry these two and bring them together across on a single platform to develop the science for the application in health. And that's where in 2015, we established a Center of Human Movement Science. Dr. Kakodkar inaugurated this, and this center was established with the support from International Society of Biomechanics. And I'll just take you through the journey of this, what it looks like in there. And this center is in partnership with Biomedical Engineering and Technology Incubation Center at IIT Bombay, because as I mentioned, it is very, very essential that clinicians and the engineers came together. So what we have is an array of activities: training, research and patient care, and of course, design of technology and validation of technology. And in terms of activities and movement, so what you see around here are 3D cameras. And these are the kinematic motion analysis and the motion capture systems, where we have reflective markers that go on the body to be able to create the models, which are then advocated and implemented and computed through the inverse dynamics principles, which we will talk about, applying the mathematics and the mechanics principle. And you can just establish and analyze and capture any motion, right from walking to standing up from a chair, to a batsman batting or a badminton smash, to a dance, or a patient either walking or squatting, and we'll come across many such movements as we move along. These are the electrodes that go on the body of the patient on a particular muscle, and what you see is the electrical activity which is recorded of the muscles, very similar to ECG if you've had an electrocardiogram, which records the electrical activity of the heart muscle. So this records the electrical activity of the muscle. And this is a pressure platform where when you walk across on that pressure platform, you would know exactly what is the plantar pressure distribution as you walk along in different phases of your walking cycle in order to understand. And of course, as we said, when we study any movement, we do take into account the heart and the lung machine for understanding the cost of the movement. Because no matter how effective a movement may be in terms of control, in terms of speed, but if that movement is not efficient enough for the person is not going to be able to perform that movement. And of course, as we spoke, body composition analysis as to what is the content of the fat, what is the content of the muscle, and what is the bone segment density like. So all this put together gives us a complete picture of what is comprehensive movement performance like. And among the different movements that we explore are right from ground level activities like a kneel sit or a squat or a half squat, to then getting up and then walking, running, sports, and of course, then spinning on to different dance motions. Now, the reason for having these comprehensive or different forms of movement to be analyzed, because in the West, when human movement science began, obviously, only those movements were analyzed which were of importance, of relevance to the lifestyle there. And in the Western population, the lifestyle or a movement relevance in daily lifestyle stops at 90 degrees of hip and knee flexion. That is like all of us are sat here, most of us in the chairs. They don't go beyond that, and which is why this entire array of movements, which was a part of our traditional lifestyle, where we essentially earlier sat on the floor to have our meals, or we sat on the floor for a lot of other leisure activities, or even daily interactions. We did not have sofas then. We had a baitak, which was low seated, but most of it was on the ground level. And a very another important activity which we performed was squatting for the toilet activities, which has now been replaced by the Western commodes, which again brings us back to 1990. So that is something very exclusive of this Center of Human Movement Science, where we are trying to analyze all these motions. And the process that it takes is generally by first having the anthropometric information of the segments of the body, because you need to have, in order to get the mathematical model created for every individual who is tested, you need to feed in certain anthropometric measurements. And after that, accurate placement of the bony surface landmarks, because that's what's going to feed in, calibrating the system, and then moving on to analyze what the forces and the motion is like. We were talking about engaging the principles of exact sciences of mathematics and physics and mechanics into the application of motion science for the understanding of biomechanics. And largely the principle that we adopt is the link segment model and the inverse dynamics principle. So what the inverse dynamics principle would suggest is that when we walk, all those pressure platforms that you saw and the force plates, here in this picture, what you see are force plates. So typically this floor would be dug, and we have force plates which are installed below the floor. So when you walk across that force platform, you have the ground reaction force vector, which is measured for that individual, and then taking into account the ground reaction force vector and the net joint moments, you would then compute what are the moments at the ankle, what are the moments at the knee, and what would be the moments at the hip, going right up to the spine. So that's the application of mechanics that is utilized for all this analysis of the motions that we're going to talk about. And when we talk about analyzing movement, we are talking about across the lifespan application, right from birth, in the maternal and the child health. So we don't start only at birth, we begin even 9 months before that, because human life begins not when we are born, so not the very birthday that we celebrate, but even those 9 months, because right from 16 to 25 weeks of fetal life is when motion begins. And it is that motion which is also giving us indications about what is going to be the developmental profile like of an individual when she or he is born. So there are a lot of interventional strategies which are coming up now, even to be able to detect these movement disorders during high-risk pregnancies, even before the child is born. So that's the application. And of course, at birth, then you talk about how can you detect developmental disorders right at birth, right at day 1 onwards, the day the infant is born, and then moving on till the childhood. And that's why the application of movement science is right up, starting from maternal health to pediatric, which we talk about until 9 years of age. And early detection, another application that we'll see through is labor outcomes and labor positions. We're placing a huge interest on the adolescent and the youth population. Currently, India is housing the largest adolescent and youth population in the world, followed by China. And we take this as pride, but we also need to safeguard their health, because that is the age when puberty sets in. That's an age where a lot of dynamic changes occurring in the body, in the metabolic profile, in the reproductive system, and of course, in the mental health system as well. So targeting there, so there is, and a lot of our health profile gets determined more or less at puberty. And it's really a very sad story that in India, particularly, we've seen this much more than countries outside, that children tend to get caged, you would say, from 8th standard, 9th standard, which is around 12 to 13 years of age, when they should be most active due to the burden of getting trained for the entrance exams or getting ready for the board exams. That physical activity tends to go down further and further. And it's only when they get into the universities and finish, by then you've lost that golden period. Of course, you still have time. There's no age limit to begin enhance physical activity, but they tend to lose that during that period. And that's where the focus is, to try and explore as many evidence-based safe movement forms so that physical activity can be enhanced, so that we don't have those typical excuses of time and space for not being able to conduct physical activity. And then, of course, last bit is the elderly, where naturally, because of aging process, an individual tends to slow down, but that's where the need is, again, first to reduce the risk of falls, and also then the osteoporotic fractures, which tend to result because of the risk of falls. Because we've seen, typically, when you have a fracture at the neck of the femur is the long bone of the thigh. So when the elderly people tend to have a fall, more common in women because of osteoporosis caused by menopause than men. There is a fracture of the neck of the femur. Either the hip is replaced or treated conservatively without a surgery. And that's when people start going downhill, because activity then reduces tremendously, and then there's mortality. So these are huge, huge causes which tend to affect life. And therefore, the breadth and depth of movement science application in healthcare is right from the birth up to the geriatric population at all three levels of care, that is within the community, at primary care level and at tertiary care level. So most of us tend to seek help here at tertiary care levels. We would go to the hospitals, we would go to the tertiary care settings, but it all needs to begin at the community level and then at primary care levels. And of course, across different body systems like the neurological systems, the cardiopulmonary system, and the musculoskeletal system. Now, this is where we're talking about at 16 to 25 weeks of intrauterine life, when motion begins. And this is where you would have first indication of any detection that is a possibility video for those children who are at high risk for developmental disorders. So it begins as early as that. And there is a lot of research that's going on to understand. Alongside, I see a few women here in the audience, and those who have been mothers and have had an opportunity for natural labor, you would have had a position of horizontal position of labor. The horizontal position of labor eliminates gravity. And of course, to be able to push the baby during the second phase of labor, the mother needs huge amount of effort, where she's already exhausted from the pain and from the restricted cardiopulmonary capacity. If we look back, traditionally, the labor postures or the childbirth postures were upright postures. If you ever get a chance to talk to your grannies or even people who from that generation, they would say that childbirth was largely at home, and most of them would have adopted an upright posture. Now, these are something that those got wiped out in the past few decades by modern medicine for the convenience and for the safety of childbirth, because obviously if you're in an upright posture, it becomes very difficult to monitor immediately the infant as it's coming out of the uterine passage, and therefore they came in. So the reason to study this particular area was to try and understand what is the pelvic outlet diameter like in the squat posture, which is such a beautiful, mechanically efficient posture by gravity. So we found that the mechanical, pelvic inlet diameter and the outlet diameter both were much larger in the squat posture compared to the horizontal posture in all these 3 trimesters of pregnancy. and therefore took then a design for a boarding table which would allow the mother to be able to squat and deliver the child, and also allow the healthcare practitioners, that's gynecologists and nurses, to be able to conduct a safe delivery and to be able to monitor the outcomes, the physiological variables of the infant when the child is born. So this is where movement science comes into picture. And of course, if you're used to squatting right up to the third trimester, that is up to the point that the mother goes in for the delivery of the child, you have a lower waist hip ratio because you're working against the gravity. So each time you squat down and come up, you are working against your body weight. So that's like a gym, a body gym in itself, work without having added weights or without having to even go to a gym for the exercises. You have greater mobility at the lumbar segment and at the pelvis. And of course, you have greater strength of the trunk and the lower extremity muscles. So this is something which was embedded in, and that's what we're trying to revive through these research projects. And now this is practiced at our Karamboli hospital. We've had first two deliveries conducted on this table in the squat posture with absolutely no complications whatsoever. And this is an ongoing process now, which we will monitor before it goes out. Mind you, this is a childbirth posture, which is given as a choice now in Canada. The Ottawa Birth Center in Canada would allow the mothers to have a choice. There are certain leading women's health centers in India. There's one in Bangalore where the gynecologist team would give, but there is lack of evidence in there to try and monitor, and which is what is being tried to create. And of course, even in the postpartum period, that is after the delivery, yoga interventions help huge way in order to bring the mother back to reducing the pain in the low back, improving the function, and of course, reducing the anxiety and depression, and therefore a better quality of life. Another application in this period in the women's health is osteoporosis. Because of the menopause, because of the hormonal and the metabolic changes occurring, the bone density tends to become much poorer. And when the bone density becomes poorer, this is when they become more prone to developing fractures with the least amount of force or the magnitude of trauma. And therefore, and as you see women, you see the huge difference in the prevalence. The pink are the women and the blue conventional boys. So 7 out of 10 compared to 2 out of 10 would have a risk to developing osteoporosis. So these are our own survey findings, that there are so many people who are still unawares of what is osteoporosis. How can that be modified? Through diet, through physical activity, and what and when do we start these interventions? And that's where we have a huge window. And then, of course, coming on from pediatric to the development of milestones. So what we record, so there is a science to this as to when does the child hold the head. We expect that the child should be able to hold the head against gravity by 3 months of age. So these are developmental milestones as to when does the child roughly come to stand without support, take a step and be able to walk. Now these milestones also are developed in the West, these charts, and therefore we did not even record when does the child is able to be able to squat. And when you talk about squat, you're talking about ascent and descent of squat. So we did a longitudinal follow-up of babies for 18 months to 24 months. And we realized that it was at the 9th month that these children typically started descent, and ascent, which is much more challenging mechanically because you're coming against the gravity. To be able to do that was at 12 months, and these are certain publications out there. And now coming on to the problems that these children typically face, and one of the very common problem that children with neuromotor developments or neuromotor delays or neuromotor impairments is cerebral palsy. This is how a child with cerebral palsy would walk. And what is essential is that movement science applications to be able to actually capture what is the impairment in the walking pattern of this child versus an age matched typically developing child, to be able to understand where is the impairment, how much is the impairment, and what needs to be done as correction. So when we do analysis of gait, now if you go to Australia, each and every child would undergo a three-dimensional walking analysis like this before the orthopedic surgeon plans the surgery as to which muscle can be lengthened. So typically what the orthopedic surgeons would do in children like these is they would lengthen the muscles which are shortened, and they would transfer certain muscles from one plane to another plane to be able to get those muscles which are stronger become the prime movers of the joints for is lacking in the country, to be able to inform our orthopedic surgeons, inform our physiotherapists, occupational therapists as to how can this be planned. And based on studies of over 200 cerebral palsy children and over 400 other cerebral palsy children where two-dimensional studies would have been done, we have now developed clinical algorithms which are going into a mobile-based application which can be used by the grassroots healthcare workers to be able to identify these neuromotor disabilities in certain basic principles of walking and in sitting and standing. So those are just a few of the publications, and this is the screening that is done. So the nice thing about MGM Institute Health University is that we are at the brink of urban and rural sector. So we do have access to the rural sector, the villages of the Panvel Taluka of Raigad district. And that's where all these findings from the research, fundamental research in the laboratory of movement science go for applications. So when we actually screened, now these mothers and these caregivers are trained with flashcards to be able to identify the appropriate red flags, that is, when is it that that child needs to be taken to the clinician. And this is funded by the Rajiv Gandhi Science and Technology Commission, and it's in the process of now being development. Another very simple variables of gait are cadence. Cadence is the number of steps that we take per minute, and gait speed is how much we walk per second. So the distance that we cover per second. And these two are very, very important variables or indicators of health or any particular trauma that we may have. So it's interesting to watch how these variables change across with age. So right from pediatric to the adolescent and then the youth and then the adult group, and you see that it again starts to fall off with aging. Gait velocity, when we typically go to our family practitioners or general physicians, they would record our blood pressure, so the heart rate. So these are seen as physiological indicators of health. Along with that, functional or the capacity, physical fitness indicators of health, one amongst them is gait velocity. You will tend to observe yourself that if you're walking into a campus like this, you would notice that if somebody is just recovering from some illness, you tend to see that that person tends to walk a little slower than her or his usual walking speed. Or if that person is in pain, they tend to walk slower. So these are certain determinants of physical fitness that are coming in, and those are being recorded to understand what is it like. Another very common movement disorder that we come across is Parkinson's disease. You may have heard about this condition, which is slowly getting more and more prevalent in the country. And that's a condition which is marked by slowness of movement. That's a condition which tends to be marked by tremors in hands and freezing while walking. So say, suppose you're walking, you're in your momentum, and suddenly you freeze. It's as though the brain forgets that I'm supposed to take the next step. And then you need to voluntarily tell your brain, tell your system that, look, I have stopped and I need to continue. So that's an organic damage that's occurring at the synaptic junctions, because of which this condition tends to get manifested. So through movement science research now, what's happening is to try and understand the earlier on profiles so that these can be predicted much earlier in the people who are already at high risk. We know who are the people who are at risk for developing Parkinson's, such as the first line family of patients who have Parkinson's. They are the ones who tend to be at the highest risk to develop. And as amongst those, there are several other risk factors which have been documented, and movement profiles do help us to tell us whether these people who are at risk for developing, and what is it that we can do to be able to intervene and find that. So these are a few publications of that work in Parkinson's. And we were talking about now osteoarthritis, which is so very common. Osteoarthritis is degeneration of the articular cartilage, which is present between the articular surfaces. The commonest joint is the knee joint, followed by the back. Less common joints in our country are hip, highly prevalent, although in the Western population. And that's where we start to worry. Why is hip osteoarthritis? I remember working from 2000 to 2008 in the National Health System, NHS in the UK. And on the ward there, out of 10, there would be at least 5 patients who've undergone hip replacement for hip osteoarthritis. Whereas when you come to India, you see hip osteoarthritis is very low. What we have very common is knee, which is common across the world, and of course the spine. But there, now we're asking ourselves a question, is this what we are going to see in the next 2 decades, even in India? Hip osteoarthritis. Is it because we are now moving that hip so little than what it was moved earlier on? And of course, because movement tends to remodel the articular cartilage. So the articular cartilage is a membrane. It's a thick, it's like a cushion which is there between the articular surfaces. It does the job of absorbing the shocks. It also does the job of providing nutrients. And this is what starts aging and degenerating as you age. And now osteoarthritis, earlier the incidence would be after 60 years of age, starting with 50 years as pre-osteoarthritis. Now the pre-osteoarthritis has come even earlier, 1 decade, and we see people in 40s coming to us with pain in the knee. Of course, there are people who come in much earlier, but they would be because of trauma, or they would be because of excessive physical activity, either on an unaccustomed physical activity. But degeneration itself is now setting in a decade earlier, which is a huge reason for concern and worry. And that's where a lot of research now to see. Now, of course, you can't reverse the changes which occur in osteoarthritis. You can't change what is the damage that has happened to the articular cartilage. But what we can do is maintain the physical function of the person, maintain the independent physical activity, and delay the progression of dependence in physical life. Because our osteoarthritis is not fatal. It does not cause damage to the life in terms of living, but it does affect how you live. So it affects the quality of the life, and that quality of life can be improved, can be resumed, and can be made more productive, more active through enhancing physical activity. These are some of the costs which all of you, or some of you may be aware of what it's like if you've had a family member or a friend who's undergone a knee replacement or a hip replacement. And even after that, the person is not able to go back to all the activities. You would come back with restrictions saying that you can sit on a high chair, you cannot sit on a low stool, you cannot sit on the floor, because once again, these prostheses which are designed for replacements are designed in the West. So they are a product of the research of the last 50 years of movement science, and those people don't need to sit down on the floor. So a lot of engineers are working now in India along with us, where we are trying to design the processes which will allow more than 90 degrees of flexion. It will allow you to go down. It will allow you to squat. Of course, the challenge is cross-legged sitting, because that's a movement in completely different planes. But what helps with physical activity enhancement, and one of the beautiful exercise, is squatting. So if you are able to get that started much earlier on life, much before the osteoarthritic changes are started on, then you are giving yourselves the benefits of complete motion at the hip and knee. Because as you see, trying to see that might come a little later. As you'll notice that when you squat, you have complete motion at the hip, you have complete motion at the knee, and then you have complete motion at the ankle and the foot. So not only that you're mobilizing 3 joints in one movement, when you come up from that squat posture, you are strengthening the muscles of the ankle foot, the knee, the hip, and of course, when you need to do all of that, your trunk, that's the muscles of the spine, that's the core muscles, both. And when we talk about core muscles, they are muscles in front of our spinal column and at the back, need to function to be able to bring that body against the gravity without you falling. So you're also challenging your postural control mechanisms and your balance systems. And that's the advantage. And we've had now a lot of evidence to say that we need to start squatting much earlier in life. If we can get our children to do that, fantastic. And that's where we will share with you another activity. And this is, of course, in the elderly. Now, in the elderly people, there are some simple things that we have been studying, because what we do not know is in India, for our population, because our population is so different from what people would be in the West, where evidence is out there. What is our functional capacity like? What's the functional capacity of a 60-year-old or a 75-year-old if she or he has an X or Y level of physical activity daily? So that's what has been assessed to be able to understand. And if you see a lot of these findings, that how it starts to decline, both in body function. So hand grip strength, we talked about gait velocity, that is the walking speed. Another important vital sign other than blood pressure and heart rate is the hand grip strength, the strength that you can grip. So you have dynamometers which are available to be able to measure that. And hand grip strength is a fantastic and a very sensitive indicator of function of physical fitness and activity. And you see that there is a decline of almost 33% compared to middle age. So from middle age, when we transition into the elderly age, and in India it is defined as above 60, that is when you are dropping by 33%. And that's a huge decline that tends to happen. And that's where there is very, very necessary awareness of how we need to bring in. And because of the body function going down in both cardiorespiratory capacity as well, our activities tend to get limited. And because the activities are limited, then our participation in daily life tends to get affected. We tend to remain more indoor, brings in depression, brings in loneliness. And that's where a lot of startups, one of the startup which is very popular these days that you see on news is Goodfellows. Yes. So Goodfellows is talking about giving company to these elderly people who are staying back in. But we need to understand, why are our elderly staying back and staying indoors much more and much before they should, or they are not able to. It's not that they can't walk, but it's somewhere because of this reduced body function and activity limitation that you tend to lose the confidence to be able to step out of the house and do what you can still do. So that's where the importance again of physical activity, even at that age, because that age you need it most. There are studies which say that, is it like an SIP plan, the systematic investment plans, that if you start investing much earlier on and if you don't do anything later on, does it help? It does help to some extent because your baseline would be slightly higher compared to somebody who's just not done or had started investing at all. But to be able to reap those benefits, you still need to keep doing that. So that's recurrent and that's something which has to be ongoing. And this is another mobile-based app that's coming out now very soon. So the Department of Science and Technology has funded this, and largely for community dwelling elderly people. So hopefully in another year's time, both these apps should be in. And now we are talking about this activity of squat. What we have from the literature so far, or what we had from the literature so far of 50 years, was a gait cycle. Because gait in itself is a science. It in itself is an area of research hugely as to what happens, which muscle kicks in, how is the control of the body like at each step of or each component of the gait cycle. So similarly, squat is being studied now so that this information can then be used by the engineers to be able to inform implant design for modeling, so that the models, the next generation prosthesis that we have for replacements for the hip or the knee, will then allow the people to go down and squat completely. So that's where that is heading towards. And these are the benefits of squat that are out there now through a very comprehensive analysis of the muscle activity, energy cost, the motion, and the postural control. Another challenging motion and another movement that we tend to now is fading out of our lives is sitting cross-legged. We sat cross-legged for a lot of our activities earlier on. And this activity is, again, a very beautiful activity because squatting is still only in one plane. It happens in only one sagittal plane, whereas cross-legged sitting crosses planes. The very word cross, you have the sagittal plane plus you have the coronal plane, which then enhances the articular cartilage on all different aspects and all different shapes. So this is an activity, but however, a challenge. And I would say if there are any mathematicians here in the audience, we invite you to join us for the mathematical modeling studies which are going on, because this is a challenge posed by two dimensions of the movement. Now, those were the activities in daily life. India is blessed with the heritage of our traditional sciences, and one of them is yoga. The yoga asanas, which most of us tend to practice, and some of us do follow those in regular life. This is a recording of Surya Namaskar. And as you see, those two blue arrows are the two ground reaction force vectors on the 2 feet. Now, through this mathematical modeling, what we now have the information is about what's exactly happening at the ankle and foot complex, say during Parvatasana, or what's happening exactly to this during Pranamasana. What is the motion that's available and happens at the hip joint? How much is the knee? In what plane? And what are the forces like? So as to now be able to inform our patients, because yoga is nice, it is hugely beneficial, but at times if practiced, the asanas in wrong conditions or in inappropriate conditions, rather than wrong, inappropriate conditions can cause adverse effects. So this is now a booklet that's come out. We're just waiting for some endorsements for yoga practitioners and even for lay people out there to understand what is the movement that's happening and when do you not perform it, in what typical conditions, and when can you continue to perform it by supervised training to begin with. Those are the different benefits of yoga, which you all are aware of, and our Google University informs us about those. So not going into the details, but Surya Namaskar is specifically a very, very simple tool for one entire cycle of 12 asanas of Surya Namaskar. It takes only 45 seconds. And if you're able to perform, say, 30 of those in a day, then you have taken care of the strength of your muscles, you've taken care of the motion, you've taken care of the postural control, that's the balance mechanism, and you've taken care of even engagement through meditation, because Surya Namaskar, when practiced with the shlokas, demands that you engage. You may just have any shloka. I mean, the conventional one is the prayer to the sun god, to the Surya, but you could just have any focus of attention, and that enhances to a large extent memory and helps to reduce stress as well. So these are different. The reason why I'm saying these different movement forms are being explored is so that you don't have to say that I don't have 30 minutes to walk. I mean, I don't have the time to walk for 30 minutes, or I don't have the space where I can walk for 30 minutes. But this is something that you could do even until you get your machine started, if your computer is not a very fast computer. So these are certain publications. And this is how it tends to benefit people with back pain, people with diabetic neuropathy. I think what we're missing here is another video, but even if that video isn't there, I'll just show you another. Do you see this picture? Where you would hold hands and go down. Some of you may be reminded of punishments in the school, but in the south of India, this is what would be called as Thopukarnam. Thopukarnam is a practice where you offer your prayers to Lord Ganesha. So people would do this 108 times. I had seen my father doing this. At that moment, as a child, I did not know what he did for. He probably did not know the benefits. He did that out of his faith and practice. And this is marketed in the West as brain gym, brain body gym. This is essentially has been a part of our life. The stimulation that you provide through the auricular points does help to bring in, because what it demands is, in religious practices, it demands that you look at the Murti of Lord Ganesha, say Om Ganapate Nama, or whatever shlok that you are citing, chanting, and you do this. But in the brain gym, they would say that you focus at a point for attention. And when we did this on our own student volunteers, they would complete 108. So we said, whatever that was possible, they took a period of 6 weeks to be able to perform 108 comfortably. And then after 12 weeks, when we studied their academic stress, we studied most importantly their ability to focus. And that improved immensely by huge 30%. 30% difference in clinical change was really surprising to us. And of course, in addition to that, we had all the other benefits that we've spoken about mechanically. So these are simple ways that we could have. I can share with you that I perform 50 until my machine begins, and until I scan through what is there on the inbox and be able to. So I take breaks of few seconds after every 20, and I'm able to complete 50 even before I begin the day at the desk, because I would have sat for 1 hour on the train before I reach my workplace. So 60 minutes of sitting and then a little bit of walk, and then you do this. So what we're trying to say is that physical inactivity is a huge challenge. In India, it is an even greater challenge, because we as a community love tablets. We love solutions that can come in as certain formulae to reduce body weight or to improve fitness, because physical activity demands engagement from us. Nobody else can do that for us, and we have to invest it. So that's why an attempt to have as many different forms as possible, to be able to choose any form that is feasible for everybody. Movement science has a huge application in dance. If you go to the Western countries, ballet in itself would have volumes of literature on every pose of ballet as to what happens to that, what we call the most distal joint of the body, where the dancer, the ballerina, would pivot herself or himself when they spin around, to what happens to the hip or what happens to the spine. And despite we having this rich, vast heritage of dance, we've only scratched the surface now with Bharatanatyam and with Kathak dance forms to be able to understand why do these people land up with pain in the back or pain in the hip, and what can they do much earlier on in their training years so that by the time they are at their peak performance, they don't have to have interruptions in their career because of pain in the knee or pain in the back. So these are the efforts that are on there. And we are now in the process of engaging with different dance schools to be able to understand. Even the structure of the foot tends to change with the exposure to the dance form. And of course, Kathak is another beautiful form of dance which challenges the vestibular system, the balance systems profusely to be able to understand. And the reason for exploring these dance forms is, one, to enhance the health of the dancers. And in addition to that, also bring in these forms as therapeutic forms to all our children and patients with chronic movement disorders. So say if it's a cerebral palsy child, that child finds it really boring day after day, week after week, year after year, to be able to go to the therapist to perform those same monotonous exercises. So to bring in that variety of movement forms is another objective of this dance research. And then, of course, traditional sports. I'm seeing that I'm approaching the time limit, so I'm going to move a little faster here. And the reason for choosing this particular very simple activity is because it's so time efficient, does not need much space, does not need huge equipment, just a skipping rope. Even if you're at the airport, even if you are waiting at your conferences and you can manage to grab, those are the benefits that you can have as compared to swimming or walking. But the million-dollar question was that we try to analyze what's happening at the hip, what's happening at the knee, because people do tend to have misconceptions that with skipping, you tend to stress your joints much more than you would by running, and it's actually not the case. You just have to ensure that when you're skipping with either some footwear, best would be any form of trainers that you have. This was a video on the grass, and that's why he's not wearing any footwear. We also have attained at an adequate speed with which it safeguards. So even the speed at which you skip is very, very important. You have metronomes now in your phones, mobile phones, so you can set those to that particular speed to be able to do that and to achieve the benefits on cardiovascular as well as the musculoskeletal system. And of course, the other sports that we have explored are Mallakhambh. These are some of our traditional sports which are still played hugely. If you go to Shivaji Park, you will see this at the Swami Samartha Vyayam Mandir. And you see this beautiful marvel of the body, literally by the hand or by the feet. There's another pose where you'll see that he holds on right by the pole and the entire body is anchored with the 2 feet. I'm waiting to see that. And so it was very exciting to see how the function of the foot evolves over the years of practice of the sport and what brings in. So these are some of the sports. Of course, cricket has huge glamour attached to it, and now it's football, but these are the sports that we are exploring. Kabaddi is coming into action, and we're very happy to say that the Sports Authority of India is now approaching us to be able to inform them as to what are the pilometric training effects in Kabaddi. Now, where is all this science going in? It's going in to inform people about different movement forms, which are evidence-based, safe to be practiced in healthy conditions for health promotion and in conditions of disease. But in addition to that, also design technology and validate technology which is designed by the others, so that that technology can then be safely used for applications of movement disorders. So till now, there have been 9 such indigenously designed devices which have been tested. And out of those, as we mentioned, these are few examples where various industries come across. This is a diabetic foot screening device. This is a device which is set for cyclists so that you know your body posture. But the moment you start stooping forwards, you start complaining of back pain, and you don't want that to happen. These are some of the prosthetic devices which are designed. And in addition to that, the center also performs training. And all this is usually funded by the Institute of Health Sciences and various funding agencies within the country and outside the country, to be able to contribute to knowledge in terms of textbook chapters. And this is the team of the master's scholars and interns, and of course, PhD scholars and faculty members, to try and cultivate the sanskar of movement. The sanskar is some which we are trying to kind of fade out in the realm of lack of time, lack of space in metros. And that's something that we need to get back on to enhance physical activity, to reduce that huge burden that we were talking about of non-communicable diseases. So thank you very much. I know this area of science is like, when you're working at a molecular level, this goes to the other pole of. But as I said, we'd be very happy if there were any mathematicians here happy to volunteer for modeling as well. Yes, sir, please.
Yeah, thank you very much for the nice talk. I just want a clarification of the comments that you mentioned about going and trying to come up with the stairs, and you said some mobile application. What exactly is that application and how it's going to get?
So the application is now in the process. So what this application is designed for is first to give people information on what are the activities that they can safely do, supervised and unsupervised. It would have an interactive media there to try and get that information from there as to where do they stand in terms of their baseline, because everybody's baseline is going to be different. And then there would be feedback on what is it that they can achieve. And it would then also have an interactive segment in there to say if there is something that they cannot perform, or something which is where the body is complaining of either pain or inability to perform. So it's an interactive mobile-based app which is being designed. And the beauty of, or the novelty of that app would be, there are several apps there out in the Western world for people who are in community dwellers particularly, and who are not able to come to a particular center, is that the reference ranges for those people are set by the Western findings, findings from the Western population. So here we are in the process, we've completed about 2/3 of it, of trying and finding out what are the reference ranges. Like, say, for example, when you go for a blood test, you know whether your hemoglobin is low or high when you are compared to what the reference range is like. So we did not have any such reference range for our Indian elderly people. So we are. This would be without any sensors for now. This would be based pictorially on illustrations of what the patient performs. Like a very simple test, which is a very valid test in elderly people, is the chair raise test. So what the test would say is that you have to count the frequency or the number of times that you can stand up from the chair at your own speed within 30 seconds, and you monitor that. So right now it's largely based on the performance after watching those videos. But there's huge room for having sensor-based applications. But this is the first one that's coming out because we did not even have anything for the reference ranges. For balance, there are sensor-based technologies which are available to try and detect if an individual is at a risk of a fall. But this is currently devoid of any sensors. Yes, please. No, increase. Increase in the ability to focus and reduction in the stress. Yes, so the ideal way to do it would be through brain mapping and functional MRIs, but we did that through the D2 attention test and the stress anxiety questionnaires. So we have not done that through the mapping systems, but there is scope to do that.
So are there any human movements which can be performed in order to reverse some cases of injury?
Injury is an event which occurs. So movement application works. So you cannot reverse an injury. You can reverse the function from the to a pre-injury status. In some cases, 100%. In some cases, there's always some deficit that tends to remain. So is that what your question is? So after injury, you can bring the person back to the pre-injury functional status, sometimes to 100%, sometimes you have to accept a deficit, depending on whether the injury is to a structure which can heal completely, or a structure like, say, for example, as we said, the articular cartilage, once it degenerates, we cannot do anything to get it back to regeneration. No activity will actually then regenerate that bit of the articular cartilage which has degenerated. But there, the attempt is to be able to maintain the function of the person. And most commonest activity is to be able to walk. So if you are able to walk, which is essential for your daily life, then you are able to then carry out a productive life, an independent living life. But you cannot restore that structure which is affected if it is that. If it's a muscle, yes, a muscle heals. If it's a ligament, it heals with certain restrictions. If it's an articular cartilage, once lost is lost.
How do you find out who's the correct person of doing
So we have analyzed the muscle activity, we've looked at motion, and we've come out with certain patterns. But we noticed that even amongst yoga practitioners and trained yoga experts, there was a huge variation. And that variation is what we are trying to bring to the point which is safer through this. So Surya Namaskar is one such composite asana for which we have completed this activity. And now it is with Ayush Ministry to be able to look at it and then endorse it. But there is a huge, as you know, spectrum of asanas where we still need to do it. And to answer this question also, we have different schools of yoga thought. So some of them would say that this asana has to be performed in slightly different way compared to the other. And we can't go into the controversies of those. So we are trying to look at those asanas where we can bring in some clarity in terms of motion and not through the schools of thought. So for Surya Namaskar, we've done that. But to be able to check each and every muscle onset act for that would be highly ambitious. But huge opportunities for technology design.
Because let's say say my mother walks or does 6,000 steps in a day, and I do that same amount just by playing 1 hour badminton. So is it is both the metrics same? Because I did it for 1 hour and she did it in let's say 10 hours, 12 hours in a day. So are those comparable?
Now, it depends on what benefits that you are aiming. If you're aiming at the cardiopulmonary benefits, that the heart and the lung benefits, fantastic. You don't have to work for those many hours to get that same thing. And that's why we are saying that even skipping, if you want to reduce your time even further, you can do that, achieve that with skipping or with squatting even earlier on. So it does not matter. Rather, something which is done, an aerobic activity over 10 hours of time is not going to accrue the same cardiopulmonary benefits as you would have in a single session. Because what we call is as a steady state or non-steady state. So you wouldn't have to worry if you're achieving that in 1 hour, it is fantastic, and it would rather be more because your intensity of exercise would be higher.
Generally, whenever a patient comes with some joint pain, we advise not to strain that joint. So is it correct or not?
And that's where we are saying pre-osteoarthritis stage. So in the pre-osteoarthritis stage, where the changes have just begun in, is where we say it is safe, and we have done studies with MRI, we've done studies with osteoarthritis biochemical markers, and with the patient's own reported measures of pain and function. And it has told us 30 repetitions of squat over a period of time, say 10 minutes, interspersed with rest periods, would be beneficial, and it is safe. And that's where we are coming to, that we don't have enough evidence to be able to say that. Now, this is the evidence we have in the pre-osteoarthritis period.
So that we will come to know only when we study that particular joint and limb. But in general practice, that is not done.
Which is
whenever person comes with suppose knee pain, I will tell the person ki cross leg mat kaito, you must go. Don't climb. But is it the correct?
and that is precisely what we are questioning. And our findings have told us that in the pre-osteoarthritis period, it's absolutely safe. Staircase climbing is not a problem at all. Because when you climb stairs, your knee is hardly flexing. Like if we are talking about this step, you're hardly flexing your knee to about 20 to 30 degrees, which is what the knee needs to do even when you're walking. So there's no reason why the person should stop climbing the stairs or come down the stairs. That's absolutely safe. Sitting cross-legged in the early stages, grade 1 of OA, is again safe as well of osteoarthritis. Now, we have not done studies in grade 2 and 3 of developed osteoarthritis to be able to say whether it is safe or not. We started because this is like, and we had huge right in our ethical ethical committee presentations itself had huge questions about the whole study, because it's such an ingrained prescription with all the doctors that if there's any pain, you're not going to sit down, you're not going to squat, or you're not going to sit cross-legged. But now over 500 people we have been able to test through radiological, biochemical, as well as functional indicators that it's absolutely safe in the grade 1 and in pre-OA state. So the entire emphasis is that in the pre-osteo, and we are continuing studies in the grade 2 and grade 3 of osteoarthritis to be able to arrive at the dosimetry. How much? Because too much is not good as well. And that's what we studied in people who need to squat for 8 hours and 9 hours for their daily activities, like the vegetable vendors or the fisherman lady who sit there down squatting below on the floor with that little table. So even excessive of that activity is not good, but the prescription for grade 2 and 3 is what we don't have yet. For a comprehensive center like this, yes, there are several gate labs in many institutes, both engineering as well as health, like several health engineering institutes would have a gait lab, but ours is a movement center because we analyze a movement right from dance to sitting to standing or squat or walk.
We will discuss further on the key table. I would like to thank Dr. Rajani for accepting our invitation and enlightening us on a totally new subject. I thank all of you for coming and sitting even if the time has passed. I thank the photography section, staff of auditorium section, and also canteen for providing the food. So please have tea.
Thank you. Thank you.
Thank you, Dr. Rajani.
Thank you, Dr. Satyanarayan. And thank you, Dr. Sandhya Raghavan, for this opportunity to be able to interact. Thank you.